All right, so I just want to introduce that we're very pleased to have our first speaker, the Honorable Justice Frank Marrocco. He is a retired Superior Court Justice, and during his retirement has been working on, is now Senior Counsel at Stockwoods, and has been working on a number of inquiries, including the Long-Term Care Commission inquiry, which reported on April 30th, 2021, which is what he's going to speak to today. And the rest of his bio, of course, you can read. And I don't know if we warned you, Justice Marrocco, that we were going to be asking, we don't generally read bios, we ask a question. And so today's question is, what was your COVID food obsession? So something you did during COVID, either you cooked or that you took in or that you learned to cook during COVID.
Well, I was fairly adept at getting stuff delivered, but salted caramel ice cream has really been my undoing, and I still can't escape the consequences of the obsession. So I had to, as soon as we could get around, I had to have a number of certain items of clothing had shrunk. And I had to do something about it, but that's what did me in.
Yeah, I think I'm with you on that one. That one was very bad for me too. So thank you very much, and the floor is all yours.
All right, thanks. I'll provide a written version of my remarks after I finish speaking. So don't worry too much about the details or the numerical information that's in it. While I believe what I'm about to say is contained in the Commission's report in one form or another, I'll issue the usual qualifier by saying the reflections are my own. Long-term care has long been an issue that needs attention and care. It's essential because all of us, in one way or another, are fond of someone who has fallen victim to the human condition and through no fault of their own can no longer look after themselves. If the province, my thought is that if the province is serious about the issue and cares to fix some of its shortcomings, it has to begin by addressing the following two aspects: staffing and all of its related issues, and the infrastructure gap. A great deal has been written about staffing, and while I propose to comment on it and give you some of my thoughts about it, I think what I'm going to do is I'm going to start by talking about the infrastructure gap. In the interest of keeping a balanced view, because so much of what we say is related to gaps and shortfalls, I think it's important to remember, as part of the context, that the Commission saw some inspiring examples of solid leadership and promising practices, and we recorded some of those instances in the Commission report. I say that so that when we discuss chronic failures in staffing and infrastructure, people understand and remember that there are leaders of long-term care facilities who do think ahead and plan for the future. And significantly, from the Commission's point of view, carry out their responsibilities admirably during the pandemic. We have to remember and acknowledge those examples to maintain a balanced perspective and to do justice to those mission-driven leaders. So what about this infrastructure gap? Well, the Commission had a mandate to investigate how and why COVID-19 spread in long-term care homes, what the province and long-term care owners did to prevent the spread or didn't do, and the impact of critical elements of the existing system on the spread. While the Commission's initial inquiries focused on care-related topics, the age and state of long-term care infrastructure quickly became important, I think. The emphasis on renewal that's part of our responsibilities we tried to bring to the analysis drew attention to infrastructure renewal, new construction, financing dynamics, economic incentives, and funding. And if at times some of this sounds like a lecture in economics, I apologize in advance, but it's my thought that if you don't understand the deal, you can't understand the problem. To put it simply, given the current and projected demand for long-term care beds, a new model of building homes, providing more beds and delivering care is, in my view, an urgent necessity. There has been relatively little investment in the long-term care sector in the last 10 years. I think the contributing factors are the increasingly complex care requirements due to the higher average age of residents, and the increase in land and construction prices in major Ontario metropolitan areas. The financial results of publicly traded enterprise that operate in both the long-term care and retirement segments reveal that long-term care home business segments deliver high single-digit operating margins. In contrast, retirement segments in the same companies had 20 to 50% operating margins. Achieved returns on investment are significantly lower in the long-term care segment than in the private pay retirement segment. What does that mean? I think it means that Ontario will continue to face challenges of attracting investment to the long-term care sector in the face of a better risk-reward profile in the private pay retirement sector. My reflection is to start with, or my second one, I guess, is that if we carry on in the same way as we have, the province needs to tell people there will likely not be a bed when they need it. How big is the infrastructure gap? Let me say it's big. We hired Morrison Park Financial Advisors, and we relied significantly on their information and evidence. So with their assistance, I think we can get some benchmarks and goalposts which help us all collectively understand the nature of the challenge. We attached importance to what they had to tell us, so let me say a word about them. I have no financial interest in them, and this is not a commercial. But Morrison Park have been providing advice to Canadian governments at all levels. Not-for-profits, cooperatives, regulatory agencies, and private and public companies since 2007. And much of their work focuses on the interplay between capital markets and public mandates. Past clients provinces of Ontario, Alberta, Manitoba, Newfoundland and Labrador, City of Toronto. So Morrison Park estimated that the cost in 2021 to construct a long-term care place or bed was $350,000 per bed. And obviously that includes all of the surrounding stuff that goes with that. In 2017, the Conference Board of Canada concluded that the price per bed then in 2017 was $320,000 per bed. So I think the Morrison Park figure is accurate. In Ontario, as I sit here, 26,500 bed licenses will expire by 2025 and require redevelopment. And there are currently 35,000 people waiting for placement. This number varies, but 35,000 is as good as any other, I think. Well, if you multiply $350,000 per bed by the wait list and the beds that need to be redeveloped, you get $19 billion, B as in Bob, $billion in today's numbers. But that is not the end of the issue, because you have to address the demographics, the expected trends in our aging population. Morrison Park advised that Ontario will require between 96,000 and 115,000 beds between now, new beds between now and 2041 to accommodate the increase or the demographics that we live with. The Aging Well report, published in November 2020 by Queen's University, agrees with that estimate. The cost of that element of the infrastructure, the cost of allowing, creating capacity in anticipation of the aging of the population, the cost of that at $350,000 per bed is $35 billion between 2021 and 2041. To put that financial cost into some perspective, the 2020/2021 budget for the Ministry of Long-Term Care was $6.9 billion, with 96% of that going into operations. Ontario spends approximately $69.8 billion in base healthcare sector spending. And I just say that to just put some kind of perspective on the 19 billion and the 35 billion. I think there's no reason to believe that the public sector alone can solve this problem. I say that because between 2011 and 2018, the province created 611 new long-term care spaces. During the same period, people over 75 increased from 870,000 to 1 million, approximately. Since mid-2018, long-term care operators have completed 5 development projects creating 12 new beds and 200 redeveloped beds. Finally, let me just say, well, two things. Age in place. I don't think, I've encountered the belief that the solution to the infrastructure gap lies in providing support to enable people to spend more time at home before going into long-term care. I think everybody supports that notion. I don't think that as a concept is seriously debatable as a preference. But based on the data of allowing older people to age in place longer would have, in today's terms, affected 1 in 9 people on the waiting list. So if you had a more developed age in place policy today, you would reduce the waiting list by 11%. Instead of 35,000, you'd have 30,000. So aging in place, I don't think is going to get it done. And finally, and this is not directly on point, but just as part of the economics of it, the Financial Accountability Office told us that in 2017, 2018, people in hospital waiting for placement in long-term care accounted for about 5% of all hospital bed days and cost the province about $170 million. So you can see that not addressing the problem creates a problem in hospitals in terms of spacing. So we need a new strategy. And to that end, the Commission proposed the complete segregation of the economics and management of the accommodation or hoteling piece and the healthcare aspects of long-term care. This segregation would mean that the burdens of the healthcare operations would no longer be an issue for the developer. Hoteling / accommodation would be provided by commercial operators. Healthcare would be provided by mission-driven organizations whose motivations extend beyond economic return. This approach would allow the private sector to satisfy the demand for long-term care facilities by accessing capital required to construct the facilities. It would simultaneously ensure that residents receive care from mission-driven providers whose focus is care and not profits. This approach mirrors that employed in the hospital sector. If you go into a hospital, you do not find care provided by Ellis Dawn or Eastern Construction. Now, I think words matter, strangely enough, in the implementation of the solution. I think describing owners and operators of long-term care facilities as either not-for-profit or for-profit is a misleading oversimplification. The correct distinction, I believe, is between mission-driven versus commercial. And that distinction describes behavior rather than corporate structure. The terminology, mission-driven or commerce-driven, focuses on the operator's philosophy and actions rather than on its corporate structure. Your typical mission-driven organization is solid on the ground, and it's exceptionally client focused. It's full of caring people. What it typically lacks is the capability to raise capital. The ability to raise capital is essential. For example, if you're looking at a sizable home that costs $100 million, you have to find $20 to $40 million in order to be able to finance it. The core value of mission-driven providers is not commercial success. Instead, they're committed to improving the quality of life of their residents, returning a profit to investors who have contributed capital to expand the enterprise's operations, will be the prime directive for commercial entities with a profit motive as their core purpose. There is no reason why a for-profit organization, using today's terminology, cannot be committed to the care of its residents and therefore mission-driven. But if it isn't, then there's, under this model, no possibility that it would be licensed to provide care. All providers have to be financially prudent in order to be economically sustainable. But nevertheless, care alone should be the focus of an organization that has a license to be responsible for operating a long-term care home. There are many entities in Ontario which focus on providing care. These are a tremendous asset to the province. And the province also has capable, well-organized, and well-capitalized companies that can build. To narrow or close the gap, you have to put together a strategy that combines the strengths of both participants. The government separates the construction of long-term care facilities from the care provided in those facilities, recognizing that those who are skilled at the former may not be appropriate for the latter. The Ministry of Long-Term Care would be prescriptive in defining the attributes of the premises that the developer was to construct. The province would publicly disclose the permissible return on equity. Letting out the contract would follow the province's established procurement procedures. The province would fund annual payments for an agreed upon number of years, sufficient for the developer to recover the investment and the agreed upon rate of return. After this period, the province would own both the facility and the land on which it was built. Developers who participate, excuse me, would earn an appropriate rate of return commensurate with the reduced risk of not being responsible for the care of the residents. In this model, the risks to the developer would be planning, land acquisition, development costs, permits, construction financing, and construction risks generally. Consistent with bridging the gap, the province, I think, has to implement a streamlined, expedited approvals process for creating redeveloped and new long-term beds. there is no reason why province procedures at the municipal level should have to be engaged in, and procedures at the provincial level have to be engaged in. And if you want to build two facilities in the same municipality, you have to go through the process twice. That sort of thing. That needs to be streamlined. There's no reason why it can't be. After construction, managing the long-term care home would fall to not-for-profit or private mission-driven operators, rather than ones motivated by dividends. The province would, subject to negotiation, pay mission-driven operators in much the same way as it now pays for operations. The province provides money and it gets clawed back if you don't spend it. There's reporting down to the penny that happens twice a year. There is healthcare activity. There is no healthcare business. There is no healthcare profit. Healthcare activity is a flow through. We're a lot closer to that model than you might think. I say that because the province already has privately funded hospitals, courthouses, and light rail systems. Those of you from Toronto know there's a major bit of courthouse construction going on Armory Street. Nobody expects that the justice system will be run by the people building the building. Each example is slightly different. All involve construction of infrastructure for paid for upfront by private operators who receive a return on their capital with profit over time. However, others operate the infrastructure, the courts, the hospitals, etc. The province should adopt the same approach for long-term care. So that, I think, is a viable proposal. I don't mean to imply that it's cheaper. It isn't. There's a cost here in order to get this, in order to stitch up this hole in the social safety net. But it's a way of pushing the problem of capitalization off onto the private sector, and the province assuming what, in your terms and my terms, like a mortgage payment. Once you make all your payments, where you live is yours. It's not the banks or whoever provided the mortgage. So I think that that's the kind of model we need. I don't think that my crude outline addresses every issue that will arise from the implementation of that strategy, but I think conceptually it's sound. So let me talk about, so that's the infrastructure gap. Let me offer a few thoughts about staffing. Staffing is critical. Saying that, no one should have paid us a cent to run the Long-Term Care Commission if we came up with that conclusion. You cannot care for an elderly, often dependent person without a competent and sufficient workforce to provide that care. I don't intend to repeat a lot of what's been said about staffing. I just want to focus on two or three things that seem important to me and that sometimes I think get lost in the discussion. It's not just more beds and more hours of care. There must also be sufficiently trained staff. I think there was a major error made in the past. The government in the early 90s advocated a system whereby people stayed at home for as long as possible before they moved into a long-term care facility. And as I said earlier, I don't think anybody that disagrees with that as an approach. But there was an unintended, I believe, consequence, or an unanticipated consequence. which is that when people get into long-term care, they're older, and in many ways, they may be sicker. The Canadian Institute for Health Information found that homes with a higher ratio of nursing staff to residents were less likely to experience a COVID outbreak. Nursing staff included registered nurses, nurse practitioners, registered practical nurses, and personal support workers. The CIHI, the Canadian Information Network, really is what it is, found that the risk of infection and the mortality rate in the first wave were greater in homes that were short-staffed at least once during the period. In December 2020, the provincial government committed to increasing the daily amount of direct care provided by registered nurses, registered practical nurses, and personal support workers to 4 hours per day, echoing an unfulfilled promise made by previous governments. In its commitment, the government reported that the actual amount of care per resident per day on average was 2 hours and 45 minutes as we sit here. We learned that the province's data reflected the scheduled hours of care instead of the actual hours of care. The province did not factor in staffing shortages, holidays, and sick days, all of which leads to an overcounting of actual care hours. The province's 2 hours and 45-minute calculation was an average, and therefore does not mean that all residents in all homes received the same amount of care. The presentation of staffing data as an average is misleading and understates the danger lurking at the extremes. In other words, describing the gap as 2 hours and 45 minutes and where we are to 4 hours where we want to go significantly understates the gap that currently exists. How is the province doing? That's the key. These promises have been made before by earlier governments, and it's not a political comment because it's not always the same political party that's in power. But to meet its commitment, the province announced in December 2020 that it would be investing $1.5 billion to create 27,000 new positions. When proclaimed, the new legislation targets 4 hours of direct personal support worker, RN and RPN care per resident per day. It sets out targets. And the first target is 3 hours of direct care per day, no later than March 31st, 2022. So it would be useful, and I don't have the information right now, but it would be useful to know whether that target was achieved. In February 2021, the province announced efforts to attract 8,200 new personal support workers. It's important to know whether the province achieved that target. As I say, statements have been made in the past about staffing, and it's just a matter of execution now. It's not a question of the principle. The 4 hours of direct per resident per resident per day care is a number that other groups have agreed upon. It's there seems to be consensus around that number at this point in time. But what is important here is not only the number, but it's the skill set. What is the skill set of the people providing the care? And I'll speed up a little bit here. 20% registered nursing care, or that's 0.8 hours, 25% registered practical nurse care, or 1 hour, and 55% personal support worker care, 2.2 hours. The registered nurses think that's an appropriate mix. The Ontario Nurses Association thinks it's an appropriate mix. We think the commission thought it was an appropriate mix. The appropriate mix of care is not a mystery. It's a matter of doing it. What is not a good idea, I think, is trying to increase staff by increasing the number of untrained people working there. I don't believe it's an issue of untrained people. It is an issue of the appropriate mix of skills that are applied to care for the resident. And the emphasis, because the residents are older, the care is more complex. And so naturally, the skill level of the people providing the care is going to have to go up, not down. Full-time, part-time. The chronic lack of full-time staff negatively impacted the ability of long-term care homes to respond effectively. There's no question in the information we saw that people want to work full-time or want to work for fewer places than they're currently working for. That's true of PSWs, and it was true of the nurses. Long-term care staff need some part-time staff because it's 365 days a year, 24 hours a day. But there's a difficulty associated with an undue emphasis on part-time work. Now, what I think is frustrating about this is that our commission was not the first commission to hit on this as a problem. In December 2003, the interim report of the expert panel on SARS and infectious disease control, the interim Walker report, concluded, and I quote, "The availability of full-time employment for many healthcare workers was inadequate. The panel believed that existing casual, part-time, and agency employment rates undermined efforts to ensure a stable and cohesive workplace." That was December of 2003, approximately 19 years ago. That panel, 19 years ago, recommended 70% full-time and 30% part-time. The Registered Nurses Association recommends 70% full-time, 30% part-time. The Ontario Nurses Association, 70% full-time, 30% part-time in all healthcare settings. We came to the same conclusion. Why wouldn't we? All of the informed stakeholders with expertise in the area came to that conclusion. Dr. Walker came to the same conclusion 19 years ago. It's pretty clear what the split has to be. The Fixing Long-Term Care Act 2021 provides that in order to provide a stable and in Section 80, in order to provide a stable and consistent workforce and to improve continuity of care to residents, every licensee of a long-term care home shall ensure that the use of temporary or casual agency staff is limited in accordance with the regulations. Problem I had is the draft regulation I was looking at didn't seem to address it. I assume there are other draft regulations coming. But it does need to be prescribed, I think. Let me just, because I see where I am time-wise, let me just deal with regulation.
Alex has kindly said you can have a bit of his time if that helps you.
Well, okay.
The next speaker.
Well, I'm not going to intrude too much on that, but just let me say this, that despite comprising the largest staffing category in long-term care homes and providing vital services to vulnerable people, many of whom are not in a position to even articulate a complaint regarding their treatment, personal support workers are unregulated. Some people told us they're the largest unregulated workforce in Ontario. I just want to make the obvious, 2 or 3 obvious points, and I can summarize them. If you have a regulated workforce, you can have continuing education. It would be mandatory, as we all know. It's a sensible thing to do. We found a lack of training and understanding in infection control practices. We weren't the first. In the expert, the Walker report, the final report in April 2004, 18 years ago, found that there was a basic lack of training in that area. Justice Campbell came to the same conclusion in his report in 2006. What happens is, I think, provinces and provincial governments and public service become concerned with the problem of the moment, the urgent problem, and that can cause them to forget about essential problems. If you have a regulated workforce, then you have a continuing education component, and you can train for things like infection prevention and control. Secondly, you need to link personal support workers, I think, to an established healthcare regulator, not some new organization, but an established regulator, because I can tell you from my own experience, you don't just start regulating something, you need experience to be able to do that. And secondly, and just as importantly, it enhances the status of personal support workers to be linked to an established healthcare regulator. I have an idea of which college should have that responsibility, but I really don't want to say, because I know that they would go, they're probably not ready for this. But as you can appreciate, they're caring for people, and there are other people on the floor caring for people, and they should all be subject to the same regulator. And apart from the improved perspective or enhancement of the image, you don't get into the cost of creating a new regulatory body. We don't need that cost lumped into this. There's enough places to spend money in here without doing that. So let me conclude this way. We owe a great deal to the generation that championed the creation of a publicly funded healthcare system intended to benefit every one of us. It would be ironic and unacceptable that a failure to address what I think are the glaring infrastructure gap and the dramatic staffing problems in long-term care would lead to a situation where we were unable to meet the genuine healthcare needs of that generation. The generation that brought us publicly funded healthcare would sadly be failed by publicly funded healthcare. So I say in conclusion, the need is urgent, I think, and the time is now. Thank you very much.